which was agreeing, so we did it. Okay, let's keep going. Sorry. You see, and we can go down to 6, ready to be extubated, but it doesn't. No, an important point. This baby is not breathing himself. He's curarized and sedated. Okay? So what we could do, well, that's a nice exercise. If you have an uptake baby because any reason, too low PCO2 or because you have heavily sedated, when you disconnect it, it's awful, you'll see. So I will do a short disconnection. What?
Shoot on the chair.
I wouldn't like to have my baby like this. You see that? That's just awful. Never disconnect your baby. And it's even worse when he's not breathing. When he's spontaneously breathing, he can keep some lung volume by himself. But when they are curarized, they really collapsed. And it takes a while to go back. It will take minutes. Unless I increase my CDP, that's another way. I hate to do that because then I don't know how high I have to go, how long I have to increase. So there are people who are using sight. I don't know if you know what sight means. It's an increase in CDP of a certain amount for a certain period of time at a certain frequency. I personally hate what is called certain. How much? Certain amount. You go from what? 15 to 20? 15 to 17? I don't know. How frequent? I don't know. Every 30 minutes? Every 2 hours? Every 6 hours? I don't know. And how long? For 30 seconds? For 5 minutes? I don't know. So what I don't understand, what I don't know, I don't do it. I like to stay all the time at optimal CDP. You see how long it takes to come back to initial saturation. It's just...
How long can we wait, sir? How long can we wait like this until we have to increase our CDP?
How long do we have to?
Can we wait this bad saturation until we have to raise
if it was, the answer is, if it was a neonate, I would never disconnect first. So if you don't disconnect, you don't have the question. Now, if you disconnect and you have the question, I don't have the answer. Now, maybe 15 until you are back to,
15 minutes?
No, 10 to 15 for a few minutes. I don't know. Again, it's probably quite individual. We never do it, so I don't have. Okay. Other question? Yeah.
Baby, when you have a hysteresis, will you do CDP trial?
Okay, that's an important point or an interesting point. What do you do with hysteresis? Do you take advantage of hysteresis? What this doctor means is that if there is some hysteresis, you could, and that's the reason for citing. That's why people are citing. But this has been shown in rabbits, but not in human. And so I don't know what it gives in human. Theoretically, if you have your compliance curve like this, you can see that this lung volume can be reached with this pressure or this one. So the principle of citing and using hysteresis is to go up there, and then you come back to a lower pressure, and you stay with the same lung volume. But, you know, hysteresis is related to the presence of surfactant. If you don't have surfactant, you will have a curve like this, with no hysteresis. And it doesn't work, believe me. So between this and that, there are many different situations. And I agree, we could. Except that I think that it makes things more complicated. So I prefer to, again, all the time being at what I call optimal CDP. My optimal CDP is always the lowest CDP that I can have with the best oxygenation. Best oxygenation being FiO2 very low. And that's why we are not citing. We could, but that is interesting because it has been shown in adult rabbits. But that's not I don't experiment that in human neonates. Okay, for me, if you don't have any question, I think that we have shown everything. You have seen how to optimize. You have seen how to win. You have seen that if you are in a good lung volume, you can have pretty nice oxygenation, even though the subject is very sick. This one was quite sick. You see also that if you're not damaging the lung and that you restore some kind of surfactant function, either spontaneously like here, either with surfactant therapy, it really helps in weaning and in becoming healthy. And you can also understand that if you need less oxygen, you need less duration of ventilation, you injure less your lung, you can expect having a better lung function later on.
How long do we wait in the lowest CDP before we extubate the baby?
Extubation criteria depends on birth weight. You may extubate 3 kilograms easier than 500 grams. My criteria to extubation is nice, quiet, efficient, spontaneous sleeping, breathing. So you have to have a baby which is nicely, quietly breathing. And when he's breathing spontaneously, you see real thorax movement. Second, low CDP. Low CDP means whatever you want. For me, it's 4, 5 in a 500 gram. It will be between 8 to 10 in a 3 kilogram. And third, most important too, is good oxygenation in 21%. If the baby still needs 40, 50%, he is not ready to be extubated. So it should be below 25. I don't care about, and something that I forgot to tell you, I don't care about the delta P at time of extubation. And the reason is that delta P is the distal delta P is extremely related to the degree of airway opening. Airway, if you have a little bit of mucus plug, you may need a high proximal delta P while the distal delta P is very low. Okay? So I don't mind too much about delta P to extubate. It's not a main criteria. At some point, it may happen again, and it's quite disturbing when it happens and you don't know about it. If you ventilate an iron membrane disease for 3-4 days, after 3-4 days, you start to have some secretion. And this secretion can become quite thick. As long as you're not infected, it doesn't really matter. The problem is that you may wonder, because you decrease your CDP as the baby is getting better, but you need to increase the delta P because you have plugging. So there is a paradoxical evaluation which disturbs you. That's why I don't care about delta P to extubate. If the baby has good spontaneous breathing, he has a low FL2 in a low CDP, whatever is the delta P, I will extubate and do a good chest physiotherapy just after it.
Directly to nasal CPAP?
Yeah.
On the CPAP of
Nasal CPAP, yeah, sure, definitely. Or
6, 7.
spontaneous breathing in a full-term baby, depending on... Pardon?
In your unit,
Yeah.
how do you overcome the problems of disconnecting while the nurse is frequently or at a certain time needs to disconnect?
For doing what?
Suctioning and
No, we suction with the Y system, Y piece. We never disconnect.
so
That's another point.
because a lot of us
Okay,
not using
have
that
that.
Y connectors.
but you should. If you oscillate, you optimize your way of ventilation. Stop disconnecting the baby. That's awful. So it costs a little more, but it will save you days of ventilation. So we never disconnect. We use this system for giving surfactant, and we use this system to suction. And again, if you don't have an infection, which is producing a lot of secretion, for the first 2 or 3 days, you don't have to suction your baby. Now, it is really a matter of being clear in your medical order. The nurses in our units know that they may not disconnect, and they don't disconnect. That's all.
Sometimes, maybe it's a very special, sometimes it's a very special condition. Maybe I want just to add what's your comment. Maybe in some point there is this very infected baby,
Yeah.
and then the mucus is very thick. We have no choice. We have no choice because in line suction with that Y connection doesn't work.
Okay.
So in that situation, sometimes we have no choice.
Okay, that's to your appreciation. So I won't go against that. What I would say is that when we start using the Y piece connector, we had the nurses really obstructing, this method of working. They didn't want, because they really had the impression that they were suctioning nothing and that it was not efficient. So what we did a study. We took 10 babies where we put either a Y system, or we were doing suctioning by disconnecting. And we have evaluated the volume of secretion we were suctioning with the two systems, while we have evaluated also the drop of PO2 and the time to recuperate the initial PO2 in the two methods. So you can easily imagine that the drop in PO2 and the time to recuperate the initial PO2 was much, much better in the Y piece than in the disconnection system, and for the amount of secretion which was suctioned, it was similar. In fact, when we suctioned the nurse, they sent, I think it's 1 cc of saline in the ET tube.
0.2, 0.3 ml.
And then they suction. So that each time they suction something. And the amount of secretion or the amount of liquid they were sectioning with the two methods was identical. So doing this study, we finally convinced the nurses to do it. And they did it. It's much better. Now, it's evident that when you have a bad meconium aspiration syndrome, that you have secretion which are really thick, and I wouldn't mind that you disconnect once in a while. But between that and some habit of the nurse to disconnect whenever they want because it's easier, there is a big difference.
Yes, and maybe in terms of that meconium aspiration syndrome, which is very so many baby here without that one. So maybe what I found I have a difficulty with in what number I have to start with that optimal CDP. With that big baby, let's say 3.8, with a very thick, very sick meconium aspiration syndrome.
Meconium aspiration syndrome is a very difficult problem to treat even with HFOV anyway. So I think that, again, if you think about the way it works, the potential advantage of HFOV, I would say I would use HFOV, especially in those situations. The problem is that meconium aspiration, you have different pathologies. You have airway disease. You have, at some point, meconium pneumonia, so a parenchymal disease. And it's mixed. If you want to treat airway disease, you tend to use high CDPs. If you want to treat pneumonia, you don't necessarily need high CDPs. To take an example, people from Utrecht in Holland, they use HFOV in treating bronchiolitis in infants. And bronchiolitis is a typical airway disease where they use very high CDPs, 30, 35, 40. Because their theory, and it works, is we have to keep the airways open, not the parenchyma, mostly the airways. And so they accept huge overdistension. So when you have meconium aspiration, you are in between an airway disease and a parenchymal disease. So again, I don't have any ideal CDP. I would say that CDP shouldn't be too high, but how high is good? Again, it's by changing your CDP and seeing what is the effect on oxygenation. On top of that, in this situation, you most of the time have pulmonary hypertension. So it is this kind of situation where you need to do more X-ray to evaluate the lung volume, because oxygenation will not help you. You may have a good lung volume from chest X-ray and being in 100% oxygen. So then you have to optimize all the things like pH, like temperature, like bicar, like PCO2 and so forth. But it stays a difficult problem. Island membrane disease is easy. Congenital diaphragmatic hernia is also difficult because normally you have a normal compliant lung with an hypoplastic lung. So what do you want to treat? The normal or the hypoplastic one? I think it's more important to treat the normal lung, so you don't need high CDPs. And you take advantage of having a CDP of 7, 8, 9 to hope that the hypoplastic lung is going to develop slowly. Let him developing slowly. And then you surge him. Again, I would prefer HFOV because I know that it decreases the risk of inhomogeneity if you use high frequency. But again, these situations are difficult anyway. Other question? We forgot the piglet.
It's too long, the desaturation.
What is the saturation?
89.
Yeah.
Maybe I'm
Not
too
better.
high. I'm overextending.
Is it okay, the water in the tubing, sir?
Pardon me?
The water in the tubing, is it okay?
No, some problem here. Yeah. It's not going in a piglet, but it will.
So where's the...
Nico? No, I should do it, but... No, that's okay. We are finished anyway.
Enggak, ininya kok.
Yeah, but I'm not...
Oh,
So,
then
by
they
the way...
have the cup to...
For your practical purpose, this, I don't know how much it costs, but it costs a lot.
6 million
Too much anyway.
in rupiah.
So
6 million rupiah. 5 years.
we tend to use it in a baby if needed. It's very rare, but maximum 7 days without changing it. It's extremely rare because it's rare that a baby is ventilated for 7 days.
Desaturation further. Desaturate.
Our baby is getting awake. I'm under standing now, I think. Go back.
Do we need to raise the
Getting
CDP,
sick.
sir?
Yeah. And we re-sterilize the circuit. The only thing that we have to care about re-sterilization are the balloon there. I wouldn't sterilize them to keep the softness of the balloon. Okay, any question? I'm finished then. I don't have any more. Have fun with your oscillator.
So in this point, I don't see you, don't even ask any question for any order for X-ray.
Oh no, you see, we manage it without any X-ray. That's nice, eh?
So it's not necessary to do that.
As long as you understand where you are, you don't do an X-ray. You do an X-ray to help you understanding something that you don't catch. So here, I had no problem to interpret the situation, so I didn't need X-ray.
So we only need one gas and not even X-ray.
Yeah,
Only that. That's
yeah.
and all
If you have, yeah.
look at the monitor.
That's another good point. And if you do a chest X-ray, if you do a blood gas, try to already think what would be the results.
Yeah.
So if there is a discordance between what you thought and what you see, then you try to find an answer. remember, when we start using HFOV, we knew that changing CDP was not changing the PCO2. At some point, when I increase CDP, I see my PCO2 increasing. First time I thought it was my system here. My electrode twist was drifting. When it happened the second time, I came back with my CDP down to the initial, and my PCO2 came back too. So there was a reason there. I was overextending. But think about where you are. And, you know, it's not dangerous if you increase your CDP for 2 or 3 minutes to see what's happening. It's not that dangerous. So do it, just to understand where you are. And if you understand where you are, you don't need a blood gas or you don't need a chest X-ray. For example, that's another point. Often, when I surprise people when I say that we're not doing chest X-ray to see where is the ET2. I don't know if you do that. Many people, they put an ET2, but they do a chest X-ray to see where is the ET2. We never do that. Because we have our repair, I mean, I don't know how you say that in English, but you know that we have we have marks. You have the black marks for the first 2 centimeters, and then you have centimeters. So when I know that I'm at 2 centimeters at the vocal cord, I know that I'm not too far. So I don't do a chest X-ray to see if I'm there, if I am in the good place. That's all details like that.
That's also you teach to your students like that?
Pardon me?
That's also the way you teach your students like that?
My student may not do anything else.
No, I mean, when we teach our residents to put the tube in,
Yeah,
so just tell the same way.
yeah, yeah.
As
No.
long as you put
Yeah.
it.
Yeah. Yeah, but it's easy. I mean, and it's depending on the birth weight. The black mark is 2 centimeters. So that's at that place for the less than 750. 2.5 between 750 and 1 kilogram. 3 centimeters if it's between 1 and 1.5, and then it's 3.5 to 4, and that's all. You at a little lower than the clavicle. So you never touch the carina when you suction. Long time ago, we used to have granuloma in the proximal, in the main bronchi. We had a few times, and because of that, we had atelectasis of part of the lung, mainly the right side. So we did bronchoscopies and we saw that we had granuloma. So we decided that the nurse could not pass the tip of the ET tube when they section. So then they do not hit the membrane of the wall of the bronchus. And since then we never have any such things.
So when do we move further into the lower CDP?
If I was in a true situation, I would ask him to breathe now himself, so that he could do it by himself. No, I don't know. I haven't paid attention to that, but I guess we should decrease. Thank you.